Folks, we have got a fine, distinguished-looking panel here. Are we ever grateful for that? Joe Braun, Sherry Clark, Greg Steele, Rich Spratt, probably one of the newest people. We have the DBS, and Dr. Larry Flake. Good to have you all here. And of course, Dr. Durr going to kind of lead everything up. But let me have your attention as we introduce Greg Davis. Greg is the Senior Executive Sales Specialist with TerraFarm Industries, and they must have grown the farm there. It's not a FAR, it's a pharmaceutical.
Right,
PAR. They thought they were good enough to bring a bunch of Chick-fil-A food, so be sure to eat it all up before you leave today. So we'll turn it over to Greg. He's going to introduce Dr. Greer, and we're going to have a great meeting together. All right, Greg.
Thank you, Hank. As Hank said, I'm Greg Davis with Teva Pharmaceuticals. I'm representative for this part of the state of Alabama. I'm out of Birmingham. And thank you for having me back up here again. We were actually here last January, so it's good to be back. I was telling Hank and Rex earlier, you guys are the largest Parkinson's support group in the state that I know of, anyway, by far. And it's just a testament to how good quality everybody is here. You know, at most events, people wait to give door prizes at the end of the night, because otherwise people won't hang around if you give it out early. So it looks like everybody's staying, so that's really good. But before I introduce Dr. Greer, I just want to let you guys know about some items that I left over here with Marion. Azilect is Teva's product, and I'm not going to, this isn't a big Azilect commercial, but I do want to let everyone know here, Azilect is an MAOB inhibitor for Parkinson's. It can be used by itself or with the other products, but there is a program we have called Parkinson's Support Solution. I'm going to leave these tear-off sheets over here that tell you about it. There's also a sign-up sheet. All you have to do is fill this out and either fax it in or mail it in. The advantages to that are if you are, and you don't have to be on Azilect to be a member of that, but if you are, they assign you a case manager who contacts you at 30-day intervals for the first 4 months to make sure you know how to take it and take things as directed. Also, they'll do benefits investigation regarding your insurance. If you are Medicare Part D, when you get into the donut hole, Teva can ship you free medication to your home. So that just is something that's a little easier than having to go get samples. There's also tear-off sheets over there of some of the medicines, cough and cold, that are good and the bad, red. So you can take that to your pharmacist. That might help them. Sometimes pharmacists want to play doctor. But also there's a tear-off sheet concerning the Medicare low-income subsidy program. You may or may qualify for that. You'd have to contact the number on the back of the Social Security Administration to know for sure. But these sheets are over there. If you are eligible, you can get your even branded medications for about $6.50 per month. And then also there are other materials over there for caregivers. There's a booklet, and then also a couple of newsletters that look something like this, just general information about Parkinson's disease and what's going on there. So I haven't said all that. Fortunately, I'm going to introduce Dr. David Greer, and we're very glad to have him here today. Dr. Greer actually went to university in North Carolina, UNC Greensboro, did some graduate work at UNC Chapel Hill. From there, he went to the state of Virginia, where he went to medical school at Eastern Virginia. He then did residency and internship at Vanderbilt, and he's been in the Huntsville area now since 2008, treating patients in neurology. He is board certified in neurology, and Dr. Greer also has 3 children, which keeps him very busy in addition to his practice. His interests lie with deep brain stimulation, movement disorders, and dementia. So that was my feeble attempt. Maybe a longer pause next time. Anyway, having said that, I'm just going to let Dr. Greer kick it off by speaking for a little while before the panelists talk. So thank you, Dr. Greer.
Thank you. Almost forgot that third one myself. I'm Dave Greer. This is the second time I've been fortunate enough to be here. I think the first time I talked to you guys, the third time I've talked to this group, which is wonderful. The first time was several years ago at a different facility down in Crestwood, but this place is great. I think it's about joining the youth group at Willowbrook. So again, here to talk mostly about DBS today. DBS is a very interesting, different take on how to treat a few movement disorders. It's indicated for not only Parkinson's disease, but also for essential tremor and dystonia. Sorry. Yes, so it was indicated, it was actually first FDA approved, initially approved by the FDA for essential tremor. And it was approved for essential tremor, and is that good? Is that better? Can everybody hear me okay? Okay, it nods in the back. Okay. It was first approved for essential tremor in 1997, and then approved for Parkinson's in 2002, and then 1 year later approved for dystonia. They were doing it before that for humanitarian device exemption for dystonia, but it's approved for those 3 movement disorders. Deep brain stimulation is a chronic, high-frequency electrical stimulation of deep structures in the brain, and they choose the structure based on if you have Parkinson's and what kind of comorbidities you may have, what kind of risk factors, what kind of things are going on other than Parkinson's. Essential tremor, they'll choose the thalamus typically. For Parkinson's, they'll typically choose a different structure called the subthalamic nucleus, and for dystonia, GPI. Now, and so they just kind of depends on what you have as to where they go with this little devices here. And it's thought to be more of a neuromodulation, so a kind of a restructuring of how things function rather than just restructuring the actual physical things in the brain. So it's not going in there and taking out anything, you're not lesioning anything, you're not scrambling anything around, you're just putting a small electrode on one or both sides of the brain in order to just basically change how the cogs in the wheel are functioning. And so that's basically in a nutshell how I think about DBS. It's nice because it's not permanent. It can be stopped, it can actually be taken out. Most of the time they don't do that. But it can be reprogrammed, and in that sense, it's a lot safer than the lesioning procedures they would do in the 80s and early 90s, thalamotomy, and basically destroying these selected structures. DBS is nicer in a way because you can reprogram it, you can turn it off, you can turn it back on, and it's got a lot of potential advantages in that regard. Risk factors, or rather risks of having any procedure done, of course, are infection and bleeding. Once in a while they'll have an infection. It's usually treatable, quite easily treated. And between 3 and 10% there's an infection rate, maybe at the skin where the incision is. Very rarely do they have brain infections. So it's thought to be overall very safe, and about as safe as a carotid endarterectomy. You know, the procedure where they clean up the artery to prevent stroke. It's thought to be about that, in that neighborhood of safety. So it's become much more routine, and it's thought to be now the standard of care, actually, in Parkinson's. So unless you have contraindications, strong reasons why you shouldn't get it, it should always be considered. Can I get a show of hands? How many people here have had their physician or neurologist raise the subject or even the idea of DBS or deep brain stimulation? Can you show of hands? You've had it? Excellent. Okay. So we're all supposed to now at least raise the idea, and again, it is thought to be more effective than medications alone. So it doesn't obviate, it doesn't get rid of the medicines. You have to use medicines with it. Quite often, DBS can decrease the need for medicines, though, and on average, people can significantly decrease their doses of Parkinson's medicines. So that's another nice aspect of DBS. So I don't want to take too much time talking about the intricacies. I know a lot of you guys, especially these guys, it's thought in general to be underutilized, but you couldn't tell it by looking at this panel. It's a good number of folks for a community this size have had it. And so we'll start with, who should we start with? I think we'll tell, each of these guys will tell their stories, okay? And then we're going to open the floor to questions. I think that's basically how the structure is going to work, right? Okay. So we'll start with Joe, you down here on the end.
How about now? All right. We have a shot here. That's the first time I've ever talked. 60 years old, and the first time I've ever talked to a large group. You believe that? Anyway, my name is Joe Braun. I noticed I had a tremor in my left hand on the last two fingers about 2002, about 12 years ago. Went to my family physician, and he said, I don't really know what the problem is. I told him several times, getting real upset at you each and every time. And then I decided that wasn't going to work, and I went to a psychologist and a psychiatrist. Thinking this is crazy. I've never heard anything or seen anything like this. And so then I went to a neurologist. And my psychiatrist, one recommendation, said, you look like you have a lot of symptoms of Parkinson's. So I went to a neurologist who said I was fine after several, an EKG, an EEG, MRI, and CAT scan, and other things you could think of. And he said I was fine. So went to a neurologist, and he said there wasn't anything wrong with me either. And I was going crazy because this has run 2 years now. And so I went to my psychiatrist again, and he referred me to Malcolm Stewart. Now, if you don't know him, he's a board-certified neurologist, trained at the Massachusetts General Hospital at Harvard, with a subspecialty in movement disorders, and a particular interest in Parkinson's disease. He is a John Cox Chair in Parkinson's disease, Presbyterian Hospital of Dallas, University of Texas Southwest Medical Center, and he's located in his own office and lab just north of Love Field in Dallas, Texas, was where I was living at the time. And he diagnosed me as having stage 2 in 2004, so 10 years ago. Stage 2 bilateral Parkinson's disease, which time after a little bit of research, I figured I was in trouble, big time. So I picked up and moved back to Huntsville, which was my home. My whole family lives here, and I knew I was going to need some help to get through this thing. And I said, is there anybody like you at all close, even anywhere in the Huntsville area? And he said, actually, a colleague of his had the exact same training, exact same schools, and he knew him very well and talked to him often. His name is Mr. Ray Watts. So Dr. Watts is if you don't know him, he was the head of all neurology in Birmingham. He's now, I think, over the whole hospital. He's the brain portion of it. He's the dean of the school, you know. That's right. I'm saying that now. So with his help and Dr. Martin Guthrie, who's the surgeon you'll meet down there, he had his surgery. Dr. Harrison Walker, who's a young guy that is very astute on the technical aspects of this work. And then you'll meet Dr. Dave Greer, who is outstanding in taking care of people. I really wouldn't have made it, I don't think, without him. And then Stephanie Guthrie, who's a registered nurse practitioner. So you'll meet all these guys going to this program. So my first operation was my left side. Let's go side. My left side. Because the brain works opposite of that implant. And so that's 2006, 2007, I hit it on the neck, on the back. right side. And then 3 years later, my battery died on the right side because the implant was placed slightly off. They're trying to cover it with a adjustment setting, so they wouldn't have to go back and operate. So you'll see my legs shaking, and they haven't quite got it yet. Even though most of you know, like 3/4 of my body is fine. You know, my hands are not shaking too badly. My leg on the whole left side's fine. So it worked out pretty well, I guess. On the right side again, I had a new battery put in 3 years after the surgery, and this little sucker here went for seven years because of its location next to, correctly, next to the safety network. So, there you go.
Testing, sort of? Okay. Subclaiming it is, right? So you
Yeah.
raise a good point. Can I just, you mind if I turn it just for a second? So
Yeah.
DBS is not a cure, and it does take a lot of, sometimes a lot of reprogramming, and we'll get there hopefully. Maybe you see a better program. And then it is, again, it's not a cure. It does take a lot of follow-up, hence a pretty stringent selection criteria. And then and when they place it in a spot that's suboptimal, it's really almost impossible to program it and get it. You know, you can't reprogram around a misplaced lead. So, and it's amazing that they get it anywhere close because these structures are very, very small, the order of millimeters. So, anyway, that's kind of goes to your point of how things work with you.
But having to do it again, I would definitely go with the surgery. And I'll probably go as early, which is a lot of people very concerning. A lot of people like to use the medications, but none of the medications work for me. I'm talking about Repic, Maripex, Stoluvo, Cinmet. I get a little relief from Cinmet, but that's about it. And I'm small. And that hasn't changed with operations either. So, expect if you have problems with shaking and concerns with medicine, you'd probably have it with the operation. I would think. This is following. It's about my story, I guess. That's all I got written down. Should I pass it on?
I don't know who I am anymore. Y'all know me, I'm Sherry Clark, and I had DBS 6 months ago in the end of July, and I'm doing just fabulous, I'm very happy, and I had my surgery on the right side. I've only had one so far, and hopefully I won't need the other one for a long time. It's a long disease, but I've had Parkinson's for 22 years. I was diagnosed at age 34 when I was in 1991. So it's been a hard road, and I decided to get surgery because I was headed for a lot of falls, and I'd gone to the point where I had gotten a walker, or one of those rolling walkers, and I thought I was headed for a wheelchair, and I did not want to be in a wheelchair. And so it had been suggested to me to have DBS about 4 or 5 years ago, and I wasn't ready at that time. And last time when they suggested it again, Dr. Hitchcock, he was a patient or a colleague of yours, he suggested it again, and I said, all right, let's do it. So he hooked me up with Birmingham, and here I am 6 months later, and I'm very, very happy and pleased with it. I'd do it all over again in a heartbeat, and will when I need to.
My name is Greg Steele, and I was diagnosed with Parkinson's first in 2006, although I had had trouble for several years and been to many heart doctors and orthopedic doctors, and pretty well you name it before I was diagnosed. As far as medications, Requip probably worked the best for me. It worked very well, but it also gave me a lot of very unwanted side effects. I won't go into the details of the side effects, but there are some of the listed side effects, and the side effects for me were very, very bad. And my neurologist, Dr. Mofer, who is here in Huntsville, suggested that I have deep brain stimulation, and oh, by the way, you got to be awake during the surgery. And I said, no way, Doc, it'll never happen. But I'm here to tell you that the side effects of the medicine get bad enough, or the condition progresses to the point, which one of my main symptoms was dystonia. You heard Dr. Greer say that it was indicated for that. My left side, the dystonia was so bad my toes would curl under. I would have cramps in my feet to the point it was hard to walk. My arms, my fingers would draw up to where it was a very painful condition. And it got to where the medication wasn't helping for that. So, needless to say, when it got bad enough, I told Dr. Moper I was ready. And I actually met Dr. Walker here the last time he was here, I guess, and talked about my problems, and he said, you need to come see me, and we went and seen him, and it progressed from there, and I had deep brain stimulation in January of last year. So that's my story, and that's it.
Hi, I'm Rich. I was diagnosed with Parkinson's probably eight and a half years ago, and was first being treated out of Birmingham by Dr. Watts, and then later came up and was being treated by Dr. Greer. And in one of our sessions, Dr. Greer asked me if I had ever considered deep brain stimulation as an option. And basically told him that I did not, because I really didn't want to go through with the surgery. But he said, it might be something you want to look into. So I did a little bit of research, and because of an insurance that we have, it could not be used down in Birmingham. So I checked with Vanderbilt, and they were able to take the insurance. It was the experience overall has been very positive. I was turned on, you could say, December 19th is when they flipped the switch and had everything firing. I didn't see anything right away when the switch got turned on. In fact, I was kind of depressed because I was like, where's all the fireworks? And the fireworks came later on. A couple weeks later, we were back home. I grew up in Pittsburgh, and I saw my friends from high school who hadn't seen me in a while. And each of them came up to me separately and said, boy, I can't believe how well you're doing and how you're moving. And I said, oh, maybe something did happen when they turned the switch on. And then I went and saw my relatives and in-laws, and many of them came up to me and said, you seem a lot looser, and you're able to move a lot better. And I said, oh, maybe something did happen when they threw the switch. So I'm looking at this as a long-term journey where working with the medicines and with readjusting the little meter, then I lost it, sorry. One of the things with the procedure, one of the downsides that I have with the procedure is that I'll be talking and then all of a sudden I'll just lose my train of thought. Well, yeah, and the doctors up there told me, they said, Rich, you just had your brain opened and you just had brain surgery, what did you expect? And I was like, well, I didn't necessarily expect that. So that has been getting better. And so I guess that's
That's a good point to raise, and it is a journey. It does take a while. Thanks. It does take a while. It takes sometimes several visits to get things programmed optimally. Although I will say, most of the time when patients come out of UAB or Vanderbilt, their settings are spot on, and you go and you readjust, and there are thousands of potential settings or different parameters. And you explore, and you go down this road, and you end up back on what Dr. Walker did, or what Dr. Phipps at Vanderbilt did. And they do an excellent job. So, and it's great to be right here in Huntsville because we have both of those centers as resources, and they're both world class. And I've been fortunate enough to work with both teams. It's just an excellent place to be here in Huntsville. So one of the questions I had for some of you guys, and particularly for you, Rich, was when they first put it in, did you notice without turning it on in that first couple of weeks, did you notice anything different?
when they first put it in, and they did turn it on, they leave it in there for a couple of weeks until, so your body can get used to it and I guess can heal around it. I did notice something, which is, what's it called? Pass effect. And I felt great. And then that lasted about 10 days. I remember because the 10th day was like, wow, I hit a wall. It was like everything had just disappeared. And I was like, no, come back, come back. So, yeah, that was...
We didn't meet beforehand and talk about this. It's a pretty common effect called the pass effect, where they put the device in and several days to a couple of weeks afterwards, you feel a benefit because it's almost a micro lesioning, and you basically create a temporary lesion. Things will go back to where they were, and then you have to turn the device on for that benefit to take hold again. So but that's something that kind of crossed my mind. But, any guys have anything to say?
As far as that effect, when I was in the operating room and they were placing the probe, I noticed that they moved it several times, and as they would move it, I could feel the tremor and the dystonia on my left side go away and come back. And like Rich said, mine actually lasted probably a month, but the symptoms did slowly come back until they got my programming to the point that it is now. So I did have that effect also.
Sometimes it depends on how many times they put the micro recording electrode. So one time, before they put the actual device in, they'll put a recording electrode, basically a listening device that's a little smaller. And if they go searching around there a few times, I guess you can imagine there's a little bit more lesion. But one of the things that's real important too, and some of you guys have hinted at this, and we'll get to Larry here in his story first before asking more questions. But I guess the expectations, we'll get to that later, kind of how that was addressed. But
I too had the immediate improvement. Lasted about 2 weeks after my last show was first place. I had Parkinson's diagnosed 2007. I was 56 years old. had symptoms referable to Parkinson's going back 5 or 6 years. And everyone knew I was disabled but me. I was the last one to give up, I guess. So. But I had a bad problem with tumor on the right side of my body. And I got my L-double up to around 1,200 milligrams, and I still had a lot of tumor. So Dr. Lynn Boyer here in Huntsville referred me to Harrison Walker. At the time of 1,200 milligrams L-double, I had a tumor that was this spare. This is not the actual tumor, this is just an exhibition, a show and tell. But when the DBS was activated, our tumor in 10 minutes or less, no. Then when I would turn my device off now, I don't get an immediate tremor. It takes several hours to develop. But I actually, I'm a grave someone. I actually have this stone in the right side of my body, my right toe will curl up on it. So if you wanted to feel what you would have been otherwise without your DBS, just turn on and see what happens. Turn it off, it'll happen. So theoretically, any system that is improved by L-double would be improved by DBS. Harrison Walker was a godsend for me because, there has been a tendency along the way for DBS to be used mainly in older patients when things aren't working out very well. But I think there's a trend now in the younger, the better, that always has to be an individualized person or those two people are the same. But it's made a tremendous difference in my life. My grandfather, my mother's father, died of Parkinson's. And the only thing that is yellow and brown tablet in my pocket, I stayed over the cinema. And my DBS only established between me and my grandfather's father. So that's basically it for me. It's been a godsend for me, a wonderful thing. But none of you have to have the other side done. The reason I have so much speech trouble is because my tumor is on the right side, my DBS is on the left side, therefore I have more speech impediment, which I apologize. Harrison Walker, we've been talking about him, but does anybody know that Harrison Walker's father is? His father is Harrison Walker Jr., who played quarterback in the University of Mississippi behind Archie Manning. I bet none of you know, huh? And when he was on his freshman team at Ole Miss, his freshman team at Ole Miss defeated the University of Alabama's freshman team. We were quarterback at that time by a guy named Kenny Stabler. Well, Harrison Walker always happens to be the quarterback's son, believe it or not.
Yeah, you raise excellent points there. That DBS will ideally recapitulate or basically reflect what your best on state is with Cinenet. So your best on state with the ideally placed, ideally programmed DBS will just keep you kind of right there. And so you notice these guys were speaking in the past tense, hopefully, that dystonia was, and hopefully hasn't bothered you as much. And that's ideally what you'll see with DBS, is that as the disease progresses, you probably have seen the graph where things will get steeper, the fluctuations, the highs where you have the extra movements, or the lows where you're freezing and you can't move. DBS ideally helps smooth that out. Again, it's not a cure, but it does substantially help improve quality of life and motor function. And so that's such a big deal with quality of life that if you do develop non-motor features of Parkinson's, you deal with those the best you can, but at least you're hopefully moving around better and have a lower fall risk and on and on. So, I don't know, have you guys seen reduced dyskinesias and dystonia? That's That's what I get for asking a yes, no question.
My improvement with the dystonia is almost daylight and dark. I went from being in pain with the drawing and my toes and arm being drawn so hard that it would hurt, to where now maybe 10% of the time I have dystonia. So the improvement for me has been dramatic in the dystonia area.
I can answer that by, one of the things that we had to go through from a testing standpoint was we had to come off our medication. I know I did. I had to come off my medication for 3 days. And at the end of that third day, I could not believe the amount of pain that dystonia was causing. I had never noticed that before because of the medication. And it's not something that I would wish on anyone. So I can only imagine what it would be like without the drugs or the DBS, the pain